Just a little bit of housekeeping for today. I will tell you out of the gate, and I've talked with several of you during intermissions, we have this meeting scheduled for 2 hours. If necessary, we are prepared to go until noon today. It is always difficult to know, although we have 3 rules, the length of time involved in discussion of those, and given we have a RAC of approximately 40 seated members today, both in the room and on the phone, we do want to make sure that people have ample time to participate. So we will do that if necessary. Bear with me, please. The RAC's role is advisory and consensus is not necessary. Our goal here is to seek public and stakeholder input to the maximum extent possible on the proposed rules and proposed changes to existing rules. Any individual is welcome to attend. However, only those specifically invited to be RAC members may participate in this discussion. All others may be able to offer public comment at the end of this meeting. I will speak to that as well. For those of you seated as RAC members, what to expect today. My name is Ralph Magrish. I will be your facilitator. My role is to lead the discussion of the rules with proposed changes that significantly alter current rules. We will collect this input and determine what we are able to accept or incorporate into proposed rule changes for the final proposed versions, and I will speak to the calendaring of that. I have several subject matter experts with me today that I will introduce momentarily. Very important now for seated RAC members, and I think most all of you have participated at some point or another in this process so far, but if you wish to offer comments that you either did not have opportunity to today at this meeting or determine after going back to your respective offices or organizations that there are additional comments that would you like to submit to us, you may do so in writing within the next 7 calendar days. So by close of business next Tuesday, August 20th, to the CCO rulemaking inbox. Please help us out by putting in that subject line as well your organization's name and comments for General RAC 5. That will ensure that we capture your comments specific to this particular meeting and these particular rules being discussed. The next piece is largely for the benefit of the general public in the room with us and on the phone. This, as noted, today's process is to gather input from seated RAC members as stakeholders that had committed to do so to help us inform what that next proposed version of final rules that will look like. As such, at that time, the general public will be able to offer comment on those. And at that time, the end of October, we, the Oregon Health Authority, will publish on or approximately November 1st in the Oregon Bulletin the proposed versions of this rule to be effective January 1st. That public comment period will stretch from November 1st to November 18th, with a public hearing to be held in this building on November 15th. All specific times, start times, and room numbers will be posted on our website in the near future. That period of time between the 18th and the 1st of the year, the Health Authority will consider those as late revisions or considerations, if you will, and determine if we should make those changes at the last opportunity before filing these rules for an effective date of January 1st. Just a couple other pieces of note for you today. As to process, we have, as I noted, approximately 40 people with, I think, some on the phone. We will maintain the same process we have thus far that seems to have worked out well for us, in that when we go through each section of rule, I will ask by show of hands who in the room wishes to speak to or ask to offer comment on this particular rule. Just by getting hands raised to get in the queue. Individuals on the phone, we will go to you and ask for your name only. Again, seated RAC members, name only if you wish to speak to this particular piece or section of a rule. We will try to alternate back and forth, and starting with who goes in the room or on the phone. Given we anticipate going 2.5 hours, we will likely take a break at the midpoint, at which point we will solicit to see who wishes to sign up for public comment. That period will last 10 minutes. If there are 5 individuals, each will be afforded 2 minutes. If there is 1 individual, it is their prerogative to speak for the entirety of the 10 minutes. As housekeeping matters as well, for those that aren't familiar, restrooms are in the hallway just behind us. RAC members and people in the general public with us today, please make sure that your phones are on mute or vibrate at this time. We will begin with introductions. Let's start to my right today.
Oh, hello. My name's
And other very important piece, sorry, we got a lot of people with us and a lot of people on the phone as well. It is imperative that you, when you ask or speak to us as the committee, that you use a microphone as well. And if there's a hard time hearing folks, we will do our best to repeat questions.
Hello, my name is Anna Kleba. I'm here with OHA and the HSD.
Hi, I'm Jackie Fabric, Behavioral Health Policy Analyst with OHA. Melissa Hanks, Deputy Project Director for CCO 2.0 from OHA.
Tom Wonderbro, Policy Analyst, OHA.
Red is on.
Carrie Trapp, Salem Health.
Jared Hefner, Salem Health.
Lauren Gieshto, Legal Aid Services of Oregon.
Sorry to interrupt. We need to honor, because we've had a number of requests, there's an agency policy that only one individual per organization can be seated. So if both individuals are from Salem Health, I'm going to ask that you determine which person will represent the organization today. Again, that's in the spirit of consistency and fairness for every other organization that has requested to be a part of this process today.
Nope, completely understand. This is actually a conversation we had earlier this morning. There was some confusion because we both got a member email for this one. So I'm going to actually let Carrie Trapp handle this one. She is our social work supervisor at Salem Health.
Appreciate it. Thank you for that.
Yep,
and thank you. Beth, go ahead.
Oregon Law Center, Beth Englander, Oregon Law Center, sorry.
Hi, Sydney Nestor, Marion County Health and Human Services.
Lauren Dion Trillium. Marilyn Berardinelli, Oregon Center for Children and Youth with Special Health Needs.
Megan Lane with Providence.
Jonathan Liebman, representing Care Oregon, Jackson, Care Connect, and Columbia Pacific CCO.
Barbara Carey, Health Share of Oregon.
Nina Sterringer, Willamette Dental. Janet Holland, EOCCO.
Alexa Lundgren, Cedar Hills Hospital.
Michael Sorensen, Healthcare for All Oregon.
Cynthia Ackerman, All Care CCO.
Cheryl Ramirez, Association of Oregon Community Mental Health Programs.
Suzanne Finnegan, Young Hill CCO.
Bill Boschka, IHN CCO.
Allison Little, Pacific Source.
Sean Parkman, SEIU 503.
Lisa Rose Gagnon, Disability Rights Oregon.
Thank you, Lisa. Go ahead, Kim.
Oh, sorry. Okay, thank you. Hi, I'm Kim Steubenrout with OHA.
And Kim is going to go ahead and take roll for RAC participants on the phone. We are going to ask those of you participating by phone that unless you are speaking, please stay on mute. We don't want to hear keyboards clicking or anything like that that are disruptive to the larger group and harder for other people on the phone to hear as well. So we appreciate that. Kim will take roll for participants on the phone.
Okay, I may have missed a few in the room, so if you just let me know, I'll appreciate it. Joelle Archibald. Ebony Clark.
I'm here.
Kristen Downey. Lakeisha Dumas.
Present.
Jeffrey Eisen. Emily Farrell.
I'm here.
Ann Ford.
I'm here.
Renee Hancock.
I'm here.
Lori Hoffman. Janet Holland. Paul Hudson. Oh, I'm here. Janet, okay. Thank you. Paul Hudson. Heather Jeffries. Erin Jolly.
I'm here. Thanks.
Katrina McPherson.
Here.
Jessica Nagelkirk. Regina Wren. Nancy Rickenbaugh.
Present.
Margaret Scott.
I'm here.
Hallie Simpson. Hallie Simpson.
I'm here.
Tina Strahan. Laurel?
I'm here. Can you hear me?
Yes,
Yes, thank you.
Robin? Trevor?
I'm here.
Matthew Verderstrassi? Jonathan Weedman?
I'm right here.
All right, thank
All
you,
right.
everybody.
Thank you. All right, we will go ahead and get started at this.
Hello? Can you June Longway on the phone?
Yeah, I'm sorry?
June Longway from EOCCO on the phone?
June, I believe we already have representation from EOCCO at the table here today. And that individual by name is?
Janet.
Janet.
Holland.
Janet.
If you could call in.
So what we would ask is that because your organization already has a seated RAC members consistent with agency policy, we're only allowing one individual per organization. So I'm going to ask at this time if you are to go on mute, we would appreciate it. Thank you.
I will do so. Holden, Deschutes County Behavioral Health.
Your first name from Deschutes County, Golden?
Elizabeth Renteria Holden.
Okay, Elizabeth, thank you. All right, we are going to go ahead and get started at this time. So while we are only going to cover 3 rules today, they are all very important rules and they are substantial rules. 2 of them are significant rewrites from existing rules. One is a brand new rule. Just to give a context, the first rule that we will be discussing before I introduce Anna to lead us through this is integration and care coordination. This rule previously was known as general requirements for integration and care coordination. For those of you, again, that have been with us for a while, this rule underwent a major revision several years ago, a little bit more of a refresh approximately a year ago, but still needed to give this some attention. And knowing that we were embedding requirements of CCO 2.0, it is undergoing yet another round of substantial revision. In addition to that, 410, 141, 3865 is a new rule that is a care coordination rule that ties largely to Oregon Health Policy Board recommendation number 24. As these 2 care coordination rules were already quite dense, we saw the need to create this additional rule, and I think that will become very clear to you through the explanation from our subject matter experts today why that was prudent. And then we will close with 410, 141, 3870, integration and care coordination, formerly known as intensive care coordination and exceptional needs care coordination, trying to bring some consistency to acronyms and potentially try to thin out the acronym soup, if you will, to try to make things a little more clear-cut for everyone. So to that point, and this is very important, and for those of you that have internet access with us or wish to look at this offline, I will say that one of the overarching themes and critical pieces to the revamping of these 2 rules and the implementation of the other rule was to ensure that we did not lose fidelity with 42 CFR 438.208 entitled Coordination and Continuity of Care. That is really the overarching federal regulation and lens that we have to bring to the entirety of this particular set of rules. So that's really the framework that we will operate within, and then putting on additional pieces as recommended by the policy board and other pieces from our behavioral health team that we will speak to. So at this time, let us start with 141-3860. I welcome Anna Claybaugh.
Hello. So I'll go ahead and give some background and context, but as you know, I believe since most of you have been here before, our goal is really to limit how much we're speaking today and hear from you. So with that, I'm going to go ahead and move forward through the rule. Some things I'd like to call to your attention. Number 4, we have added innovative, flexible, and creative strategies. I'm going to go back through it page by page to try to break up, and I'll pause. So on this page, number 4, 4C, MCEs shall engage other primary care provider models to be the primary point of care and care management for members where there is insufficient PCPH capacity.
And just for people following with us on the phone today, that was actually 5C that she just referenced.
Thank you. 5C, moving forward, 6 6A, we added a second sentence there. If the member does not choose a primary care provider or primary care team within 30 calendar days from the date of enrollment, the MCE shall ensure the member has an ongoing source of primary care appropriate to their needs by formally designating a practitioner or entity. I'm going to pause there and ask for any feedback.
And can we just show by show of hands in the room who's going to wish to speak? At this point, I'm only seeing Dana and Sean and Beth Englander from the Law Center, Bill Buska. I'm seeing 4, I'm seeing 5, I'm seeing 6. Apologies to those of you who in the room who my vision is just not good enough to see your name tags. May I also pause before we begin in the room and just by name only, RAC members on the phone by name only that will wish to get in the queue to speak on this particular set? For just what we've covered. I'm sorry?
Laurel Swordlow.
Laurel, thank you. Anybody else? All right, Laurel, since you're the only one, let's start with you actually, and then we'll go to the folks in the room, starting with Dana. Go ahead, Laurel.
Thank you so much. I was looking through, and I went back to some of the other rules that we've reviewed over the past couple weeks as well, and I'm looking for a definition of coordinate. Is that something that exists?
No, at this time, but it's something we'll definitely take a note of.
So, Laurel, if I can ask, because we want to make sure we capture all requests.
Yeah.
So is that a request to provide a definition of either care coordination or the singular word coordinate?
Yes, I think that would be helpful.
All right, thank you. We appreciate that. I'm going to go to Dana Steringer in the room.
Dana Steringer, Willamette Dental. Just wanted to make a general comment about this rule, and actually for all 3, but I'll reiterate it when we get to those rules, that the term MCE includes plans that are dental only, and I believe that most of these terms and the requirements are related to CCOs as they were developed, and I'd like to request that this rule be limited to CCOs.
And we will take that under advisement. Thank you. We appreciate that comment. We're going to stay in the back of the room. Again, apologies, I can't see name tents. We'll stay back there, and then we will go to Sean from SEIU. And then we'll circle back, I think, to Cynthia and whoever is next to her, and we will get there. So.
This is Barbara Carey, Health Share of Oregon, and I'm making a general statement on subsection 3.
Okay.
This appears to be new and requires coordination of a specific set of benefits and services that are both Medicaid and non-Medicaid services, physical health, behavioral health, IDD, and ancillary services. And the services must be coordinated with other MCEs, fee-for-service Medicaid and quote-unquote community and social support providers. How will the CCO know about the Medicaid services being provided by other entities and the non-Medicaid covered services that the member is receiving? Will OHA provide information to the CCO? It will be difficult to comply with this provision without a reliable source of data.
Thank you for that. We will note that concern. As of now, our response would be that through coordinating with the other interdisciplinary team members, that is one way that you would be able to keep track of what your members' needs are. And regarding information from OHA at this time, that is not part of the plan. We'll definitely note your concerns moving forward. Thank you.
And the gentleman in the back of the room. You, yes, sorry.
Hi, I'm Jonathan Weekman, Care Oregon, JCC, and CPCCO. This is in reference to Section 3. It states ancillary services between settings of care, including appropriate discharge planning for short-term and long-term hospital and institutional stays. I was curious if this is in reference to short-term hospitals, that every single hospital stay we are going to need to provide transition of care for a member. And I would just say in terms of burden upon a large health plan, that could be many, many transitions of care that maybe are not necessarily appropriate. Not everybody needs care coordination via the health plan for every transition. So just some clarity would be great in that Section 3.
And can I ask a follow-up question there just to make sure we're tracking? You spoke of transition of care, which is, we all know, has its own specific meaning and rule set. In number 3, where are you extrapolating the reference or the requirement to
It says
conform?
appropriate discharge planning there in section 3 for short-term
Okay.
and long-term hospital.
Sure, so just to provide that context, transition of care has a wholly different, very broad contextual meaning, so I want to just make sure that we're doing a listen check, because I heard you say transition of care, but you're really speaking by volume of the need to ensure safe and appropriate discharges.
That is correct.
Okay, thank you. We will capture that. Next at that end of the room, I'm going to just ask folks to figure out amongst themselves down there who would like to go next. No, we are really only through section 6. All right, no problem. And
Hey, can you hear me?
yes, thank
All right,
you.
so it would be 6A, and I think more than anything, it's just...
Cynthia, apologies for the benefit of everyone on the
Oh, I'm
phone as well.
Cynthia from All Care.
Thank you.
CCM, sorry.
No problem, thank you.
One of those mornings. Okay, just for the benefit of everyone, keeping the language consistent in 6A, at the beginning it says demonstrate that each member has a primary care provider. Then we would recommend that it's in that same sentence, provider of any eligible MCA participating primary care provider type. It's just restating primary care.
Okay.
Instead of just leaving that open.
So we will clean that up. Thank you for bringing that to our attention.
Cheryl Ramirez, Association of Oregon Community Mental Health Programs. I have a general clarification question and then a specific question concerning, let's see, it's 6A. So my general clarification question is that the community mental health programs that our association represents are having kind of a difficult time discerning whether they would be included as MCEs or not. When I look at these rules, I see many responsibilities of community mental health programs, and to the health share's point about non-Medicaid services, CMHPs definitely manage and provide non-Medicaid types of services for these members. So I would really like clarification on who is included in MCEs and in what circumstance. I think we need that throughout all of the rules, all of the RACs that we've been involved in so far. We are confused about that. And in this one in particular, I wanted to ask a question about, that was 6A. So the primary care home, is that limited to PCPCHs in this rule? Or are you talking about a primary care home for someone with a behavioral health diagnosis, so that would be more of a behavioral health home? Or is it really limited to those who have primarily physical health needs and secondarily maybe behavioral health?
Thank you for your feedback. My understanding is that it would be any primary health setting, so behavioral health care home would also qualify for that.
Is that something that could be specified? Because I don't see any reference to behavioral health home in these rules.
Yes, we can definitely add that note.
Okay,
Yep.
thank you.
Thank you. Beth, I want to recognize that I think I've missed you. Let me stay with this side of the room, and then we will come right over there. I also want to note, though, that this is great, and I meant to say this during the introductions, the very broad representation we have today at this table, not just of plans and advocates, but individual community organizations. Been doing this for a long time and really thrilled to see the number of folks representing different community organizations today. So we thank you all for being here. And continuing on. Bill, I think maybe?
I'll pass.
Okay.
It's already been covered.
And let's go to Sean Parkman from SEIU, and then we'll go to Beth Englander from the Law Center, and then to Carrie Trapp from Salem Health. You have my word.
Thank you. Sean Parkman from SEIU 503. So first, just a quick question. The appropriate discharge planning in 3, is it defined somewhere else in other rules?
Discharge planning is, but not necessarily appropriate discharge planning.
So with that, I have kind of a general statement that has an application in several different parts. In general, there's a lot of these rules are written without specificity, without defining some of what we mean, the intention. So, for example, appropriate discharge planning, maximum extent feasible in number 5. In 5B, patient-centered primary care home in a timely manner. And C, under 5C, insufficient primary care, patient-centered primary care home capacity. These are all terms that if you were to ask an organization, are you appropriate? Or did you do that in a timely manner? What organization would say no, currently? And if there's no definition of that, then why have it in rule? Because of course they're going to do what they think is appropriate or timely. So I just point that out, that those kind of need some definition or some sort of, if not a definition, some sort of intention or a nod to some guidance somewhere else that actually has some mechanism for accountability and measurement about these things.
No, and we appreciate that feedback, and likely the safe and appropriate discharge would be a good example of that, as I could say with a high level of confidence that under other state or federal laws, there are requirements that hospitals must abide by in terms of safe discharges and appropriate discharges. So to that point, we can look into certainly providing a level of clarity and qualifying there, recognizing that it is a balance in trying to not be so overly prescriptive that it is limiting to people that potentially could access service, limit accesses to services to others, but we definitely appreciate what you're saying.
Yeah, thanks for that. It's sort of a question of like, what does the rule add? You know, yeah.
Sure. So to that point, and for folks that have been with us earlier, a lot of the rules are written at a higher level to provide the framework for a specificity that is provided in contract. So I don't want to lose sight of that, but we absolutely hear you. Let me go to Beth Englander, and then we'll go to Carrie Trapp, and then I will do a check-in on the phone.
Thanks. This is Beth from the Oregon Law Center. I have a question. And I'm asking forgiveness ahead of time if I am missing this in the rule, but it looks like this is the general, like you just said, Ralph, like sort of the high level, this is the intention of the agency in respect to this rule, and it's integration and coordination of care. And I'm just not seeing anywhere in this rule where it explicitly says that NCEs have the duty to coordinate care for people outside of the transition of care context, outside of the coordination, if people are in multiple systems, let's say, the DG system and the health system. So I'm just looking for a statement that says it is the duty of CCOs to coordinate the care of their members.
Sure. So to that point, and this is part of the balancing act, and appreciate the feedback, and we will take that under advisement. We know that and apologies if folks were with us in one of the earlier RACs, but in the covered services rule, we made point to add very specific language that the MCE or the CCO shall be responsible for the coordination of physical, oral, and behavioral health services and integrate. It is the balancing act for us in trying to have brevity in the rules where we can, and to remove redundancies, but I hear you loud and clear, and that I would think that in a situation like this, as a table setter to a rule of something this important, that something like that would be appropriate. So we appreciate that.
And I'll just mention that when courts are interpreting rules, they'll look to the general rules, but they'll place extra weight on the specialty rule that's supposed to go into the detail about, for example, integration and coordination of care. So I think it's although it may be redundant, I think it's important since the rules are split into so many different sections to make sure that the main points and principles are really hit in each one.
Thank you. We appreciate. Yep.
And
Go
then
ahead.
Sub 2.
Okay.
MCE shall develop, implement, and participate in activities supporting continuum of care. I request that the word participate in change to provide. Just to be clear, participate in could mean a really wide range of activities, and I think what we're hoping for is that this will be something that this MCEs will literally provide. And then I'm not sure we're not up to 8 yet, are we?
No.
Okay.
No. But thank you for both of those. We'll recognize Carrie Trapp from Salem Health.
Thank you. In the rules, when it talks about hospital stays, have we defined that? Is that an acute care hospital? Is that a behavioral health hospital? That would be helpful. The other part that would be helpful on this end is when folks admit and they're still open card or fee for service, how quickly can we transition, and will the hospital stay impede ability to transition to CCO if it's necessary?
Sure. So I doubt we have the right subject matter experts today, but I welcome if you.
I don't have a direct answer to that one.
Okay. Let us take that one offline, and we will follow up with you as we're keeping a rolling list of things that do need follow-up. I think it is reflected in other rules. I just can't speak to what they are at this exact moment. Let me do a check-in on the phone. Is there anyone else that wishes to get back in on this before we move on? Just by name only, RAC members.
Renee.
Renee?
Robin Traver.
Robin, okay. And was there anyone other than Robin? All right, Robin, go ahead.
I think there was someone before me. I think you said Renee.
Was there a Renee?
Yeah.
Okay, Renee, go ahead. Thank you for that, Robin. Renee, you've got the floor.
Okay, so 6C, I believe it is. MCEs shall services and supports for primary care that are geographically located. I would advocate that the health component was added in there to say MCEs shall develop services and supports for primary and behavioral health care.
Thank you for that, Renee. We appreciate. All right, Robin Traver from Umpqua. And Renee, what organization were you with? I'm sorry.
Robin or me, Renee?
Renee.
Oh, with Bridgeway Recovery Services.
Bridgeway, thank you. All right, Robin Traver from Umpqua, go ahead.
So I just have a question on 4D. Can you clarify what the statement means that CCO shall administer the PCPCH program and receive program required reporting? Should that be deliver program required reporting, or what is that referring to?
It's actually 5C, sorry, or 5D rather.
5?
Yes.
Yeah, sorry, 5D.
Oh, 5D. 5D.
Can you repeat the question?
Yeah, should that state receive program required reporting or deliver program required reporting? I'm just wondering what this is referring to.
This is Jackie, and we will have to get back to you with that response. Thank you for that question.
Thank you.
Sure. No, we'll check that one back. Allison Little from Pacific Source.
I just had a similar question. It's really unclear whether or not what the intention is there.
So we need to provide clarity there. Thank you, Dr. Little. All right, we're going to move along to the next section unless there was anyone that didn't get opportunity. We'll do one more here in the room, at the end of the room. We're just getting a microphone.
This is Barbara with HealthShare. I just have a question on section 6, sub A and sub B. If you could explain how they're different, because if I assign someone to a PCP in section A, would that also meet the requirement for section B?
This is Anna. If the member is not, has general care coordination needs and is not in a prioritized population, which we'll discuss in the future rules, then it would make sense that yes, A would meet the needs of B, as long as that primary care provider can provide that general care.
And we can provide that level of clarity as well, so thank you for that. All right, Anna, I'm going to ask you to continue.
So moving forward, if anyone, we kind of did half of 6 there, so if anyone wants to provide feedback, we'll provide feedback now from 6C all the way through, let's go all the way through 14. So I'm going back to 8. We added some relating to transitions of care requirements under 8 to be consistent with our transition of care requirements and other rules. Moving on to 8. E, big C, little e. MCEs shall ensure that the member and treatment team participate in discharge planning activities and support warm handoffs as defined under OAR 309, 032, 0860, parentheses 30, between levels or episodes of care. Specific requirements for MCE care coordinator, participation in transition and discharge planning are listed in OAR 410, 141, 3865. That was added in correspondence with our organ performance plan. Number 12 is also new language. We added that that these services should be provided in a linguistically and culturally appropriate manner. We note in 12A that rule has a specific number that is not filled in here, which we will add. And I think that is where I will pause for questioning. Any questions from there? Again, 6B all the way through.
Actually, let's go all the way to the end of 15, because I think that after that, once we get into 18 and on, there will be a specific set of discussions around that.
Okay. Continuing on with 15, new language also is in 15B and C. B reads, the MCE shall coordinate the discharge planning when the member returns to the county of origin. C, if a member loses Medicaid coverage while in an episode of care, the care coordinator will continue to manage the member's care until Medicaid coverage resumes. And with that, we will pause and get a show of hands for response.
All right, we're seeing hands in the room, and can I do a check-in on the phone first, name only, if you wish to speak to these rules, this particular set of rules or the section of rules?
Robin from Umpqua Health.
Thank you, Robin. Anybody else? All right, we will check back with, go ahead, sorry.
It's Nancy Rickenbach.
Thank you, Nancy. All right, we will start in the room, and then we will circle back to Robin and Nancy. Let's start, and I did see a lot of hands. Apologize, didn't capture all names. I see Bill Buska and Beth Englander from the Law Center. Let us start with Bill first, and then we'll go to Beth.
This is Bill Bushko with IHNCCO, so I have a view with this.
It is imperative, thank you.
No karaoke.
No karaoke, too early. Go ahead, Bill.
So I have a few on this, so I'll just do one first and I'll jump back in the loop. It is 8D. I think it's like the last sentence where it says the MCE shall pay for the extended care benefit when appropriate. The request put in the word medically appropriate in front of that.
All right, thank you for that. Let's go over to Beth Englander from the Oregon Law Center.
Thank you. First, in sub 8, referencing something you mentioned earlier, Ralph, this does specifically say members shall meet the following requirements, MCEs shall meet the following requirements related to transitions of care. And I don't think you mean transition of care. I think this is talking about something else. If you do mean transition of care, I think you need to distinguish from the transition of care rules in 3850, or say in addition to the transition of care rules in 3850 for the people that fall into the categories that you're describing below.
Thank you for that important comment and helping to distinguish that.
Also in 8 sub A, I am just unsure of practically how do people who, the end of the paragraph you're talking about, including transitional services and support for people with serious behavioral health conditions, basic admission to or discharge from acute psychiatric care. If folks have been in acute psychiatric care for a long enough period of time, they're taken off of Medicaid if they're in an IMD. And so how are they still assigned, how would they have an MCE that's coordinating their discharge planning? Is there a plan to start Medicaid enrollment early, or to plan for Medicaid enrollment and have them be on the CCO rolls even if they're not quite yet Medicaid eligible?
So I'm going to defer to my two subject matter experts here. Our two subject matter experts, rather.
Okay, Beth, thanks for the question. Oh, sorry. Am I on?
Yeah.
Okay, I'm on. Okay. So I want to first clarify your question. Thank you for the question. I want to make sure I have the right response for you. So are you speaking specifically to state hospital?
Yeah, I mean, that's an acute psychiatric care facility, so I assume people will fall into that.
Okay.
And some people do stay for long periods of time at other acute care
Right.
facilities, so.
Right, so specific to the state hospital, there was SB 1549 that has that members aren't to be disenrolled upon admission to the state hospital any longer. So there are, let's see, there's a couple of rules related to that, and some specific rules around admission to the state hospital, pending discharge, once ready to discharge, and upon discharge, in terms of communications. So does that help answer the question?
I think so. So the plan is just to not take them off the CCO rolls at all?
Mm-hmm.
Okay, that's great. And then to clarify in sub C, 8 sub C, where the rules are asking MCEs to help people find long-term care facilities that are appropriate for them. Is that the intention?
For those that would be appropriate or eligible for long-term care supports and services, LTSS, yes. And again, that's part of maintaining fidelity to the CFR that the original rules were framed around.
Great. And then in sub D, what will, we know that people get stuck and are not able to transition even if they are medically ready to transition. There isn't a place for them to go, or the places that are available for them to go refuse to take folks. So what happens after that 20-day period? Who is paying for the continued stay where people are, because transition is not available to them?
And we may not have the right subject matter folks here, but we'll capture that, and as with other questions, we're capturing to provide a responsive set to push back out to RAC, to each individual RAC member, or to the entirety of a RAC after they conclude. So we will follow up with you there.
Okay, great.
And
then in sub 10, the rule states an MCE may cover and reimburse inpatient psychiatric services, and we'd like to request clarification of under what circumstances will MCEs cover, and if the rule will not lay out the criteria, then at least ask and require, that the MCEs have a written criteria by which they will decide whether someone will be approved or not approved for that.
And Beth, which letter subset, where it's specific?
It's
10.
in 10, the main, not a subset.
Main 10,
just 10.
okay, thank you.
Mm-hmm. And then, we went all the way to 15. In sub 12, and the requirement is an MCE shall demonstrate that participating providers have the tools and skills necessary, and our question is, how will they? Will there be a report issued, and will that be made public?
I believe there is a reporting requirement in one of the other rules as it relates to these requirements. We can confirm that.
Okay. Great, and then in sub 14, is the agency's anticipation that the NCE shall coordinate care while in placement and discharge planning for return to the county of origin, even if that requires coordination of care with facilities that are out of the network?
Yes. Yes, so moving forward in the other rules, we'll get into more detail on that.
Okay, great. Thank you. And that's it. Thank you.
All right. Let me recognize the gentleman from Health Share in the back again. I'm sorry, Cynthia, and then we'll go to you and the person next to you.
Thank you. Jonathan, Carol Reagan, JCC, CPCCO. Mine is in reference to 15, Section C. If a member loses Medicaid coverage while in an episode of care, the care coordinator will continue to manage the member's care until Medicaid coverage resumes. I just have a lot of concerns around HIPAA and those kind of confidentiality pieces, given that once someone is no longer on our coverage, we don't have access or should not have access to their care any longer. And so if we continue to provide that, I have some concerns around confidentiality and HIPAA.
Okay, thank you. And let's go to, I think, well, go ahead while you're there, and then we'll go to Cynthia.
This is Barbara from Health Share of Oregon, and I'd like to comment on Section 8E and subsection 15. So under 8E, my question is involving the warm handoffs for care coordination will add incredible administrative cost to the system and really may add little value to the members. Comment. And then subsection 15, again, we would like to know how this rule interacts with the new rule that was discussed last week that's essentially eliminating the home CCO rule for children in out-of-area placements. Which rule controls in that situation?
Sure, I will invite Anna to speak to the first one, and then I think Jackie specific to the second one, although it may not be an isolated conversation relative to the rule discussed last week.
Well, I think regarding your first comment, we have noted that, and then did you have a specific comment, Jackie? You have a second? Yeah, I'll definitely write that down and ask which presides regarding the CCO rule question.
Jackie, are you able to speak? No? Okay. All right. Let's go to Cynthia Ackerman from All Care.
You know what? I just lost my screen.
Aha.
Do you want mine?
All right. Whomever at that end of the table wishes to speak, and apologies, I'm seeing a couple hands. We'll ask you to go in whichever, from far end of the room to closest, and then we'll get Cynthia back in the queue, and then we'll go to the phone.
Alexica Lundgren, Cedar Hills Hospital, Section 10. We're asking them to remove the exclusion for substance use disorder treatment within an IMD.
you.
Is that a question or a comment?
Requesting substance use
okay.
disorder be included. So remove the exclusion, include substance use disorder.
Thank you. And we'll come, I'm sorry, to the woman to Cynthia's left, unless she's ready.
I'm not quite ready.
Okay.
Thank you.
Sure. Go ahead. Yes, thank you.
Cheryl Ramirez, ASMHP. I want to reiterate my request for clarification of the definition of an MCE, and because there are examples in this section, I wanted to call those out. So, Section 9, it talks about an MCE coordinating with social and support services, including crisis management, community prevention, and self-managed programs. That's certainly a role of a community mental health program. Yet in 9C, it requires agreements established with local mental health authorities and community mental health programs operating in the service area. So that just seems a little bit murky to us. And then I just want to I have another example in 13. These kinds of transitions of care from the state hospital to the community, that's certainly a role of the community mental health program as a choice contractor working with CCOs and KEPRO. So it's a role of ours, and we just like to have a little bit more clarity on what MCEs are. So is that something you want to provide?
So, I mean, we've captured the comment. I think the general response is that a managed care entity is based on a federal definition of a risk-bearing entity that the state of Oregon is contracting with to provide that service, whether they provide through a subcontract or not, being a separate and distinct issue, which comes with its own bundle of reporting requirements on top of that. But in terms of managed care entity, that would be the risk-bearing entity that in this case would be the CCO or the DCO, which as discussed is not terribly relevant to this discussion. So we would likely need to look at this in terms of being CCOs.
So would that mean then that if a CMHP is bearing risk, they would be considered an MCE, but if they're just getting fee-for-service, DMAP rates, they're not?
I don't believe so in the construct of this conversation and a managed care entity based on a federal definition of it. But I will have to look into that. So, but we appreciate the comment. And Cynthia.
Thank you for your patience. This is Cynthia from All Care. And my comments have to do with 8D and then go down to big C.
Okay.
Below that. And I guess I'm a little bit confused with 8B for members who are discharged. And as that sentence goes on, it talks about those that would fit 8C, but yet it doesn't really specify. It's more of a coordinating the transitions with the DHS, the appropriate department. So it's a little confusing, I think.
Sure. Would you, do you have something in mind either today or in writing that you would like to offer?
Yes, thank you.
Absolutely.
I actually think that the language in big C, shall coordinate transitions to Medicaid-funded long-term care, actually addresses, I think, what was trying to be described in 8 little d.
Thank you. We will take that under strong advisement. All right, let me go on the phone first to Robin Traver, then Nancy Rickenbach, and then we'll come back to Bill Buska in the room. So Robin, go ahead.
Yeah, my questions have already been addressed. Thank you, so I'll pass.
All right, thank you. Nancy.
Same for me, Ralph.
All righty.
They've been addressed.
Bill Buska.
This is Bill with IHN CCO. Asking for some clarifications on 10, the last sentence, where it says the state may meet monthly capitation payments. It's kind of confusing. I don't quite understand what that is, Jackie. I don't know if you can help with that one at all. I'm not quite sure what it's stating or why it's even necessary.
Sorry, thanks, Bill. Thank you for your question. I think we're going to have to get back to you on that one.
Okay. Down in 12A, it cites a health equity plan training and education. With their health equity plan training and education, it might be an incomplete statement, but the health equity plan, it's just called the health equity plan and rules. I don't know what that's referencing. I have some of the same concerns also about when someone loses Medicaid coverage and the MCEs continue to be responsible for them when they're not an MCE member. As an example, 15C, I think somebody already cited that when someone loses coverage, or when they're in the state hospital and they're not our member, being responsible for coordinating care. That is difficult, but it sounds like Jackie said that they're going to maintain enrollment when someone's in the state hospital. Mm-hmm. And oh, that's good information. When is that going to happen? January 1st, when these rules are in place?
Oh, I can't seem to work a mic today. Oh my goodness. Okay. Let me get back to you on the date that that's going into effect. It's according to SB 1549.
Right.
All right. Thank you, Bill. Did you have anything else? I'm sorry.
No, I'll wait till a little bit later.
All righty. Last check-in in the room by show of hands or on the phone. All right, we're going to do, anybody on the phone? All right, we're going to go to Sean Parkman from SEIU, and then back to Cynthia, and then we'll move along.
Thanks. So under, which one is it? 8 subsection E. This is the warrant handoff that everyone's been talking about. So is the phrase literally warm handoff actually defined in OAR?
Mm-hmm.
That's amazing. All right.
Got that one.
That is oddly colloquial. All right.
There's nothing to shed a light on that. That is part of the U.S. DOJ settlement as it relates to the Oregon performance plan. So.
Very good. Okay. So everything else has been covered. I did want to make one last statement though on 15C, this new provision, 15C. So member loses Medicaid coverage while in an episode of care. Care coordinator will continue to manage the member's care. And maybe this is just because I'm an outsider in the medical system. Is it just encouraging OHA to consider that continue to manage a member's care is clearly defined somewhere else? As like, what does that mean? They will continue to provide coverage. They'll continue to check in on the fact that they don't have coverage and they're going into medical debt. They're just keeping tabs on that, or like they're trying to get them to have coverage with someone else, or like what does all that mean? Yeah.
Thank you for your question and feedback. We definitely want to clarify some of that. So I think the key word in C is that if a member loses Medicaid coverage while in an episode of care, the care coordinator will continue to manage. So because this is the integration and coordination law or rule, then this is referencing that the coordination will continue. And this was basically put into place to help to have really truly comprehensive care. So if a member is in the hospital for a couple weeks or whatever, that they are able to still have their care, and if someone's watching them through those steps, it's not, well, that's not our, it's trying to work on the de-siloing our system a little bit.
So I'm going to show one more. Sean, did that give you?
I really appreciate that clarification. All of what you said may not be held in that one sentence.
Yes.
So potential some clarification. All right, I'm going to do Dana, I'm going to have to limit after Cynthia because I need to move us along. My apologies, but reminding everyone that you will have opportunity to provide additional comments in writing. Knowing we're going till noon already, I feel like we're pretty ambitious. So I'm going to go to Cynthia, and then we'll close on this piece and move on.
Cynthia from All Care. This would have to do with item 19. And it's just not clear if that's going to be a tool that's developed for consistencies.
Sure. So actually, Cynthia, that's a perfect stopping point and segue because we had hard stopped right at the end of 17. So we're going to tee up and ask Anna to give the overview and context for these, and then how about you'll be first up there. Does that work? Okay.
Thank you. So we're going to go ahead from starting with 18 through the remainder of this rule. So new language is adding that care coordination must be done in a manner that is trauma-informed and culturally responsive. 19 is new, that they should monitor the effectiveness of their integration and care coordination, must implement at least one outcome measure tool for care coordination services at the PCP managed care coordination level and one at the ICC care coordination level. CCO shall collaborate with the authority to develop statewide standards for care coordination and ICC. 20, the MCE must report semi-annually to the authority on its care coordination activities. The MCE is subject to appropriate corrective action by the authority if the contents of the report reveal that the MCE's care coordination requirements are not being met. The report must contain an identification of care coordination practices used with members, an overall review of care coordinators performing services for the MCE, separated by employed and delegated or subcontracted care coordinators, identification of any significant events that occurred to members, data on frequency of triggers for reassessment exhibited within the reporting period, activity logs of care coordination services, plans and strategies to improve care coordination with network providers, and reports of member grievances related to care coordination with corrective action plans to improve common grievances. 21, the MCE must identify a plan to improve the overall process of care coordination access for its members. This plan shall also include discussion of gaps in care coordination services and populations that need additional support and plans for improving the care coordination system within their CCO. This plan is subject to approval by the MCE board and must be updated semi-annually with milestones and accomplishments. With that, I know we have Cynthia and go.
Yep, so let's get a show of hands first in the room in addition to Cynthia. All right. And can I just do a check-in on the phone? Who wishes to get in the queue on this? All right, we will start with Cynthia, and then, apologies, ma'am, we will go to you over there. I just can't see your name tent from this far away. So Cynthia, go ahead.
Okay, thank you. This is Cynthia from All Care. So number 19, I guess I'm looking at this from a consistency standpoint across MCEs. And is this going to be a tool that's developed by OHA? Again, consistency purposes. I see that all of these other elements will be included, which is good. But again, I would advocate for some type of formal tool so that everything is captured the same way across the MCEs. And then my last comment is on number 21, and it's the last sentence. This plan is subject to approval by the MCE board. Could that also include a quality committee oversight rather than just the board?
We'll note that. Thank you.
Okay, thanks.
And we'll go, yes, ma'am. Can someone hand her a microphone, please?
Marilyn with the Oregon Center for Children and Youth with Special Health Needs, and I have a general comment related to plans to improve care coordination with network providers, which is also related to transitions of care. So specifically for youth with special health needs who are transitioning from pediatric to adult care, I would like to recognize the importance of the coordination between the pediatric and adult systems so that youth and young adults are not lost to care during that critical time.
Thank you for that. We appreciate it. And staying on that side of the room, go ahead.
Hi, this is Lauren from Trillium CCO. I wanted to just mirror Cynthia's comment regarding the tool creation, really looking for that standardization, and then also with 20, considering a templated report so we have consistency across the board. And then also mirroring Cynthia with the 21 with the quality involvement.
All right, thank you. Let's stay on that side of the room with Beth, and then we'll move over this way.
This is Beth from the Oregon Law Center. Question in 20 sub D, part of the reporting requirement is data on frequency of triggers for reassessment. I have just missed what that refers to. Are regular reassessments required for the coordination to determine what adequate coordination of care is required for each individual?
Yes, so in the upcoming rules, that we should clean up that language, I agree, since it's a little bit unclear there. But yes, there are certain things that would require reassessment for care coordination, which we'll go into. And so part of these reporting is knowing the frequency of when those triggers are happening.
For intensive care coordination?
Yes, but we'll continue in more moving forward, but it's also to help trigger the CCO to know when someone becomes from a general to an ICC level.
Okay, yeah, that it would be really helpful for that to be clear, that it doesn't.
And those are in the next rule.
Yep.
So those are in the next rule that we'll be discussing.
I get that, but
Okay.
maybe referencing in this rule.
In this rule, okay.
Refers to assessment for services in the next role. And then just lastly, this is sort of reiterating a comment I made before. Again, it doesn't state in this particular rule that care coordination, it doesn't come across clearly, that care coordination is specifically required for every CCO enrollee. And I did just glance back at the covered services rule that we discussed in an earlier RAC, and it also doesn't state clearly in that rule, it doesn't say the word coordinated care
Okay.
in that rule. So I feel like it's really important. I did request that it be added in covered services, but I'll ask that it also be specifically restated here.
All right, we appreciate the comment and the question and the request. Got it all. All right, may I just see by a show of hands here on this side of the room that's going to wish to speak? And I think someone down that way. Let's start with Sean from SEIU, and then we'll head down that way. Just so people know, I think after this rule, we will take a very brief 10-minute break. At that time, I will seek to see if anyone wishes to go for public comment at the end of the meeting. So Sean, go ahead.
Sean Hartman, SEIU 503. My statement or point is on 20. It's unclear by 20 if this is to be publicly reported, at least the way I read it. I'll just advocate that that there be at least some components of this reporting process that's public for two purposes. One, public transparency and accountability. But the other is to support a learning community, because why it seems that it's inefficient for one CCO to relearn a lesson about coordinating care that another CCO has already learned. So just advocating for something about publicly reporting or learning community, something.
Thank you for that. Let's go down here, and then we will come back to Dr. Little, and then we will close on this. Go ahead.
Barbara Carey with Health Share Oregon. Excuse me, this is just a general statement for subsection 19 through 21. OHA does a really good job of stating how the reporting will be used in subsection 20. But these potentially onerous requirements could add administrative costs that will make it difficult for CCOs to direct more resources to member services and community investments.
Okay, thank you for that comment. Let's go to Allison Little from Pacific Source.
Thanks. This is pertaining to 20 subsection C, identification of any significant events that occur to members. I have no idea what that means.
So definition of significant event. All right, thank you for that comment. All right, at this time, I'm showing 10:40. We're going to take a very brief 10-minute break and then continue on. Before folks make too much commotion in the room, everyone on the phone that is with us from the general public today, is there anyone that will wish to offer public comment at the end of this meeting? Please state your name at this time. All right, thank you. We will, go ahead.
Lisa McMahon from Oregon Foster Youth Connection.
All right, thank you, Lisa, very much from Oregon Foster Youth Connection. We appreciate. Anybody else? All right, we will reconvene at 10:50 sharp. Thank you. Thank you. Returning from our break, we are reconvening our Rules Advisory Committee this morning, Tuesday, August 13th. We have approximately 1 hour of time left before we hold for a public comment period. Talking up here at the front of the room, what we are going to do is we are going to time limit the discussion for each of the next two rules to 30 minutes each. And we are making absolutely positively certain that everyone at the table knows that if they do not have opportunity to speak today, you are not foregoing an opportunity to offer your comment. You may do so in writing to us by close of business next Tuesday, August 20th. So I'm going to welcome Anna now to provide the context and introduction for 410-141-3865 care coordination requirements.
Howdy, welcome back. Yep. All right, so this rule we decided that we needed to write in due to policy option number 24 regarding care coordination requirements, also following pertinent stakeholder advice or recommendations that we beef up our standards for care coordination. So I'm going to go ahead and move forward. So the first, I'm not going to read the whole rule in the interest of time that you have it in front of you, but I'm going to highlight the big sections and then we'll pause halfway through for feedback. So, number one, the CCO will ensure continuous management for all members, not only those in ICC or specialized programs, through episodes of care, regardless of the physical location of the member. It must do a health screening for each new member, which will assess for critical risk factors that trigger the need for intensive care coordination. I want to call out on 2B, there is actually a typo here. It states that the screening needs to be done in the incorrect days. So the contract actually indicates that it must be done. The first number should read 30, not 90, and the second number should read 10, not 30. So the screening shall be completed and documented as quickly as the member's health commission requires, but at least within 30 days of the effective date of enrollment for all new members, or within 10 days.
And RAC members in the room and on the phone, we will get you out a marked version of that, probably close of business tomorrow or by Thursday, so that you will have a clear understanding of what that edit is for your comment and review.
So moving forward, the rest of this page talks a little bit more about the screening and what that needs to entail. Moving on to the next page, we go into what a care plan must include, a member's care plan, including when it needs to be developed. So it needs to be developed at 5D now, be developed within 30 days and updated annually for all members not in ICC or in a specialized program. For all members enrolled in an ICC or specialized program, care plans must be developed within 10 days of enrollment. And then moving forward to, I'm going to go take this all the way up through 7. We'll stop there. And 7 says, a member may decline care coordination in ICC. The MCE shall explicitly notify members that participation is voluntary and that treatment or services cannot be denied as a result of declining care coordination. With that, let me see a show of hands, please, who would like to provide feedback.
All right, let us do it. We're going to have a pretty robust conversation here. Let me do a check-in on the phone by name only. RAC members who would like to get in the queue here.
Robin from Mental Health.
Robin, thank you. And who else?
Elizabeth Holden, Deschutes County.
Deschutes County, last name was Holden, sorry about that. Elizabeth Holden. All right, we have you in the queue. We will come back to you. Let's start in the room. I see Cynthia Ackerman's hand. Then we will go across the table. Apologies. Next to Beth Englander.
Lauren Gieshtow.
Thank you. We will go over here and then to you, and then we'll go to the back of the room.
Cynthia from All Care. I'd like to start with number 1 with some feedback. Episodes of care, is that defined somewhere? It's a question.
Yes, it should be. I know it's in the contract, so it should also be here. We'll double check.
We'll have to double check that.
Yeah, I would add that. And then in number 2, when I see for each new member, that's 100%, and there are members we are just not able to get hold of. So I don't want to lessen the restriction or the requirement, but there has to be some kind of language that allows for not being able to contact someone.
Yes, there is language in the next rule, but that's a good point for here.
Okay, thanks.
Yeah.
All right, and Lauren, sorry.
This is Lauren Gieshtow. And how far in the rule is it, are we doing comments for the whole rule, or do we stop at a specific section?
Through subsection 7.
7, okay. So specifically subsection 2, when looking at the screening process, we request that the requirements be fleshed out to include what that process will be, will the details of that process be public, and we also request that the screening is designed to find people who have issues that may cause trouble coordinating care, such as language barriers, specific conditions that cause trouble, not just multiple conditions.
Thank you.
For section 5, we'd like to clarify that, I guess the question, does every member get a care plan?
Yes, the general care plan would suffice at a PCP level, so that would suffice for the care coordination if the needs are basic.
And then section 6D, we understand that there are some people who can't participate in their care plans, but we would request that there be some safeguards. Specifically, we request that it be added, that there be a medical necessity determination that shows how rare or how severe the consequences should be before a member is excluded. Something like imminent, substantial, or severe health risks, something like that.
And we request a statement by the agency, specifically stating how rare the circumstances should be. Additionally, if you look at the sort of the second half of that on the next page, that this decision must be reviewed prior to each plan update. We request, it be clarified who reviews it, what's the process that it's reviewed, and what are the criteria that are used. And sort of as a safeguard on the back end is we request that there be a way for a member to contest the exclusion from their care plan or the denial of a copy of their plan.
Thank you for that comment and feedback. Let's go to Cynthia Ackerman and then the gentleman in the back of the room and then staying in that over here, and then we'll go to Dana and then we'll come back to SEIU and IHN.
Okay, Cynthia from All Care, I missed a comment on 2F. And just because of some of the strict rules regarding consent, I would clarify the conditions and diagnoses that need that extra consent, like HIV.
Yep.
Okay, thank you.
Thank you. And go ahead, sir.
This is Jonathan, Care Oregon, JCC, CPCCO. This is in reference to 2B. Just would ask humbly to reassess the days that you just stated were 30 days and 10 days. It causes a great amount of administrative burden to do it within that time period, and traditionally folks do use 90 and 30 days as appropriate times to screen. So that would be a comment. And then also 6A, languages to ensure engagement and satisfaction with care plans. Members shall participate in the creation of care plans. Just to keep in consistency to the spirit, which I'm seeing lots of language around when appropriate, we would ask that you say members shall participate in the creation of care plans when appropriate. There's plenty of detail about when that is throughout the rest of the rule.
Thank you for that comment. We'll go to the corner over here and then to Dana Steringer.
Marilyn from the Oregon Center for Children and Youth with Special Health Needs. This is a general comment in regard to care planning and children and youth with special health needs. I would like to recognize the range of community-based services that contribute to physical, social, emotional, intellectual, and developmental health for our population of kids, and this includes social supports addressing the social determinants of health and how these are different for kids than they are for adults, and to ensure that care plans include services, community-based services as such.
Thank you very much for that. Appreciate it. And Dana, go ahead.
My comment is around the applicability of this rule to MCEs generally when dental-only plans don't typically have the sets of requirements that are listed in this rule. Care coordination is definitely something that the dental plans do, and so if there is going to be some care coordination requirement rule for dental plans specifically, we ask that that be separate from the CCO rules.
Okay, thank you for that. I think we're going to go to Sean and then Bill, and then I need to honor the folks on the phone here, being Robin and Elizabeth, and then we will come back and recognize Lisa Rose Gagnell from Disability Rights Oregon.
Sean Hartman from SEIU 503, just actually adding on to a comment previously made. So in 6, there's, care plans shall reflect goals, member preferences, and will be trauma-informed and culturally responsive. So my point is similar language, it seems, would be appropriate around the health risk screening. So in other words, it should include the outreach and the cultural responsive in the risk assessment itself, because if you can't get people to describe their needs because they're afraid of the medical system, etc., you're not going to be able to get them the plan. So some parallel there. That's what I'm requesting.
Thank you for that. Appreciate. We're going to go to Bill and then Robin and Elizabeth holding on the phone.
This is Bill from IHM. A couple general comments. The language between screening and assessment kind of keeps going back and forth, and it gets confusing. What is the difference between, do you screen to assess for something, or when it uses the word assessments, is that a different document, a different thing, a different process? For example, in 2, C, where it says members shall be reassessed annually, is that an assessment or is that re-screening? It's kind of confusing going back and forth between those things, including into E, where it talks about assessments. So I would just like some clarification on what you just said about in 5, a member's care plan. So that's a PCP care plan. It's not a MCE care coordination care plan.
Depends on the level of need with the member. So if the member meets prioritized population or special health needs and qualifies for intensive care coordination, which we'll get into the next rule, then it would just depend. But yeah, does that make sense? No.
Yeah, but it does, but it's not clear at all in here. The way this reads and the way I read it at first is that every member has a care plan. Then that's an MCE responsibility. Because a care plan to me is more of a care coordination thing. It includes multiple things, and a treatment plan would be something that the PCT would do. But I think that's another area of clarification. What is, what's a care plan, whose responsibility is, what's a treatment plan, what's an individual plan of care? Those terms keep going back and forth, which adds confusion. So we read the section 5, meaning that every member needed a care plan from the MCE.
Okay.
Okay, I'll stop it.
Alrighty. Let us go to Robin Traver on the phone, then Elizabeth Holden, and then I suspect after Lisa there will be other folks that wish to get in the queue here in the room. So first Robin on the phone.
Robin from Umpqua Health Alliance. Under section 2, it refers to a health risk screening that's distinct from the assessment of special health care needs. Are there examples of these 2 documents? Can the OHA provide the documents that they use for fee-for-service members? So there's kind of a standardized form or assessment. And then similarly for number A, or little a there, it refers to a universal screening process. What is this process? Is there a definition for this? Is this different from the health risk assessment and a special health care needs assessment? And then lastly, under C, there's discussion of members shall be reassessed annually upon a change in responsibility. So what does that mean? Responsibility from whom or what? And what type of change in healthcare status would trigger this?
Thank you for your questions. This is Anna. I can answer that upon a change in responsibility, that would be responsibility of care provider. And change in health status, that would be any other time that indicated another behavioral health assessment based on change in level of care acuity. We can add detail to make that more clear. Thank you.
All right. Elizabeth Holden from, I believe, Deschutes County. Go ahead.
Yes, just on 1, regardless of physical location of member, just knowing that there's some discussion around how that capitation might change, particularly for kids in BRS and other placements, just wondering if there's some links that might be made there so it's clear what that is meant by that. I similarly had a question on 1A about the critical risk factors in universal screening. What direction are we going to be providing folks around that? And then 2D about when a member overutilizes services, what is the definition or how are people conceptualizing that? And then lastly, under, I believe it's 6C, about care coordinators actively engage members, ensure they understand their role and that they feel equipped to fulfill their responsibility. Just, any guidance about how people are to, quantify that, if they feel they're prepared or if they understand their role.
Thank you.
Thank you for that. Appreciate it. All right, we're going to recognize Lisa from Disability Rights Oregon. And can I just see, by show of hands, still in the room, who else is going to wish to speak? All right, I'm seeing 4. So after Lisa, we will just go around this side of the room, and we'll just ask at this point that those individuals that have their hands up speak. We will do a time check after that to see how much longer we can go on this piece. Go ahead.
Lisa Rose of Disability Rights Oregon. I'm referring to 6D, and I would like to just ask if there is a person or an organization that is named to be determining the risk to the individual who would be not able to access their plan, and also just echo Lauren Hermosa's concerns around criteria and access to contest that decision.
Do you want to, can you restate the first part?
Yeah, so in here, it does not state who is actually would be determining whether or not there is a risk. So it would be good for us as well as the person in question to know who would be making that decision.
Great.
And then just seconding Lasso's concerns.
Thank you. And we'll recognize Allison Little from Pacific Source.
Thank you. I want to echo the comments made by Jonathan from Chair, I believe, about the burdensome nature of 2B and request clarification as to why those numbers were changed from 90 to 30 and 30 to 10.
All righty. Yeah, go ahead.
Some of the clarification on the 90 to 10 were decisions made by the team at OHA due to supporting our complex cases and getting them the help they need sooner, and knowing that if they have not been identified, 90 days is a long time for our prioritized populations to be unsupported.
This is Barbara from Healthshare, Oregon, and I would like to offer some general comments and questions under subsection F. Basically, this further increases costs as well as risks of data breaches, and so we would ask that OHA adopt the universal health risk screening tool, that upon members becoming eligible with OHP, they would be provided this assessment during determination and redetermination, which would benefit the annual requirement, and share the results electronically with CCOs and other entities to which the state assigns members for care. Under subsections 4 and 5, number 4A, basically it states that care coordinators shall develop and MCEs shall require their provider network to use individual care plans to the extent feasible. But if a primary care provider's office already has a care plan, we feel that is really better for the member instead of requiring a provider to use an MCE's care plan. And then subsection 6D, we feel is a little paternalistic, and it sets up a scenario that is ripe for abuse and creates risk for CCOs to violate members' civil liberties.
All right, thank you for those comments. Beth, sit tight just a moment. I think, was there anyone else between you? Let's recognize the individual between her and Beth, and then we will come back to Beth. And then, did we have someone else? So we're going to do Beth after her, and then Carrie Trapp from Salem Health, and then we're going to move along. We are at about 10 and a half minutes left for this particular rule, and we still got half of it to go, so go ahead.
Hi, this is Lauren Dion from Trillium CCO. Wanted to discuss or note the care plan, that every single member requires a care plan. But then moved and must participate in the development of the care plan, but then later in 7, members may decline. So there's kind of a discrepancy there whether the member participates or not, and that level of requirement.
Okay, thank you. Beth, and then Carrie.
This is Beth from Oregon Law Center. I'm getting increasingly concerned as this discussion goes on that there is confusion between treatment care plan and what I think this rule is addressing is coordination of care plan.
Yes.
And so we're asking that it be clarified that what we're talking about is in addition to treatment care plans, or maybe a section of a treatment plan. People also have separate rights to their own participate in their treatment plans, and if this is intended to cover both of those, that's also fine. But it should be clearly laid out what care plans we're talking about and what they contain and what they don't contain. Thank you.
Thank you. And we will go to Carrie Trapp, and then we will close on this and keep going.
Okay, this is in regards to care plans, and this may be addressed in contracts, which I'm not privy to, but
Will the care plans be visible and accessible to community partners when there's an episode of care? And if that can just be noted.
We'll note that, and if there is consent, then yes, our goal is for as much integration between providers as possible.
All right. Anna, I'm going to welcome you to continue with the rest of this new rule.
All right. Moving on from 8 through the end of it. 8, it talks about just overall roles of the care coordinator and what they will do. Wanted to note also some specific language regarding discharge under 9A, B, and C. Regarding C, for discharges from an acute care admission, the care coordinator shall have contact with the member within 1 business day of admission and 2 times a week while the member is in acute care, and no less than 2 times a week within a week of discharge on a face-to-face basis if possible. I'm going to go ahead, I imagine there's some feedback on this, so I'm going to just pause and go ahead and ask the room.
We show by a show of hands first in the room. I'm seeing 1 hand, 2, 3. All right. Can I do a check-in? Anyone on the phone, seated RAC members only, wishing to speak to this? Anything in the second half of the rule? All right, let us start. Robin, all right, anybody else?
Going through the entire, to the end?
To the end, yep. All right, we're going to start with Robin, and then we'll work with Lauren from Legal Aid Society, and we will go around that direction. And again, oh, you reset my clock.
I did.
We're going to go about 7 more minutes with this, folks, so I'm going to ask you to respect the opportunities for your neighbors and contemporaries and be brief. Thank you. Let's go ahead with Lauren.
Robin.
No, Lauren.
So I'm Lauren with Legal Aid, and we have a question if it's the agency's intent for Section 8 that everyone assigned to a CCO gets a care coordinator that provides this level of care coordination.
If a member needs this intensive care coordination, that's one thing. This rule is just our general care coordination practices, and this rule just states all those in general, so no, not necessarily.
Not sure
That's
consistent with what you said earlier.
I need the question. Can we repeat the question, then I can make sure I have my head together.
Yes, so for Section 8 specifies the care coordination that a care coordinator, what they perform and the amount of coordination they have to do. And we want to know if that applies to everyone that's assigned to a CCO. Do they get this level of care coordination that's in Section 8?
Yes.
Yes, I mean, yeah, I mean, there's a high-level obligation that all plans meet the care coordination needs of all their members, consistent with the comments that Beth made earlier, consistent with many of the conversations that have occurred during the week. I think it's incumbent on us to go back and look at the level of detail and specificity we put in the rule language on that, which we are committed to doing, so. Sure. And I'm going to move us along, staying on that side of the table.
Jonathan, Care Oregon, JCC, CDCCO. This is in Section 9. This entire section to me reads as if it's all about ICC versus, I'm not sure why it's embedded here versus it should just live within the ICC OAR that we're going to be discussing next, because it becomes very confusing about providing all of these levels of care when it seems to be language that's specific about ICC, such as state hospital, residential care, all the time limit expectations. It just seems to me like what is being referenced here is mostly around ICC. I'm not sure the intention around having it in this section. And then down to F, it says specifically around the individual tasked with such responsibility must be a licensed master level mental health professional. So that to me speaks to behavioral health ICC versus a general physical health ICC. So again, it just seems confusing about the language and why it lives in this OER.
Thank you for the feedback. I can say one of the reasons why this section might have been included here instead of the ICC is because being put into a facility of any kind is considered a reassessment trigger, which will go in for ICC. So we'll go into that in the next rule, and again, consider being more specific on the reassessment or screening concerns we talked about earlier.
And go ahead.
Yeah, there we go. Janet Holland, EOCCO. So I would echo what Jonathan was saying in terms of concerns around the language in 9, in particular for B, the 2 days post-discharge, because I don't know if that's a contract change, but I believe it's 3 days currently. And so just for clarification around that. And then also just a language issue on D and E, it says CCO, and then it says COO. So just in terms of catching that from that
typo,
thank you.
Typo. And then the last one is, regarding F, regarding clarity about licensed mental health professional, just in terms of some that would seem to exclude RNs and other care managers. So just wanting some clarity around that.
Thank you. Was there anyone in between you and Dr. Little that wished to speak? Bill Buska, then Allison, then we were going to honor Robin's request on the phone, and then we're going to time this one out.
Okay, so quick rally. This is Bill from IHN 8A, big B, kind of the quality of the care coordinator, what they will do. G, have contact at least twice a month. That's a very big burden. I agree with a lot of the sentiments about 9 and that it's way beyond just basic care coordination. So this goes way steps past that. Again, for discharges from the state hospital, they're currently not our members, and maybe they won't be our members January 1st, but how will we be notified from the state hospital about these different timeframes and when to engage if they do become our members? In 9D, prior to discharge, it doesn't say from what, so this is one section where it doesn't say from where that you have to do something. And then in E, I'm not quite sure how we would know that it's a lapse in Medicaid coverage, or if it's just someone loses their Medicaid coverage. We will never know that, so it's really hard to understand what a lapse in Medicaid coverage is.
And I think, Bill, real quick, we're going to ask Jackie to speak to at least a point or two of your questions, and then we'll continue over here.
Yeah, thank you for that comment. So the OSH Benefits Coordination Unit will be notifying the CCOs upon admission to the state hospital, second pending discharge, once the member is identified ready to discharge, and third upon discharge. And if there's no CCO history, a CCO is notified prior to discharge and a release of information is needed.
And last in the room will be Allison Little from Pacific Source, then Robin Traver from Umpqua, and then we will move to the next rule.
So this is pertaining to 9, and there's multiple areas of 9 that I have concerns about. First of all, it may be because I don't understand what a specialized facility is, but it appears that this is referring only to behavioral health. And I think that needs to be clarified, particularly under C. It says for discharges from an acute care admission. Well, is that any medical admission, or is that only behavioral health? If it's medical, it's pretty unreasonable to expect this level of care coordination for gallbladder removal or something like that. And then I have real concerns about the lapsing coverage issue. This, again, seems to be potential for HIPAA violation. If they're not our members, we cannot do this.
All right. Thank you for that. We will go to Robin on the phone.
Yeah, Robin from UHA. So we have a concern also with just operationalizing number 9, and it just doesn't seem realistic. Some of these requirements, for example, under 9B, the face-to-face meetings or the face-to-face visit with the state hospital or residential care, that could require, depending on where the residential care facility is located, sometimes it's outside of Oregon, it could require our care coordinators to travel long distances, and it just seems like a waste of resources.
if you would like to offer that feedback, but I think it is important to note that that is the opinion of one individual in terms of a waste of resources and trying to access appropriate care and services for an individual in need. So go ahead.
And I would like to add that our definition of face-to-face does include the option of televisits. I have to triple check on our definitions, but I'm pretty sure that is in there.
Okay, thank you. Robin, we appreciate your comments. I am going to move us along to the next rule and reset the clock for 30 minutes. This is intensive care coordination, 410-141-3870, and I welcome Anna to provide this overview.
Okay. So again, this rule was really beefed up after having pertinent stakeholder feedback and asking for us to do that, in addition with the Oregon Health Policy Board number 24 for increasing our care coordination practices for vulnerable populations. So go ahead and read some things that changed. 1, MCs are responsible for intensive care coordination services. The requirements described herein are in addition to general care coordination requirements described in the rule we just went over. Prioritized populations is a definition that is very big in our new CCO 2.0 world. Prioritized populations mean individuals, I'm actually not going to read that, but that's our whole definition under 2. And 3 also identifies members with special health care needs. Many of you know that this was our ENCC rule before, and because they were using both words interchangeably, we have gone with just intensive care coordination moving forward. There are additional populations included in this group due to us honoring our federal block grant requirements and other vulnerable populations that OHA deemed need additional support. Moving forward further down, talking about the screenings, that we MC shall have established process for the screenings within 30 days. Regarding their eligibility, MCs shall reassess members for ICC eligibility, revise care plans if necessary, and ensure care coordination is after any of the following events within 7 days, unless the member is already in ICC, in which it should be 3 days. So these are what we kind of were calling reassessment triggers that I mentioned earlier. So all of these are different things that would trigger the need for the CCO to reassess or rescreen. Again, we'll work on that language for ICC services. I'm going to go ahead and pause there. So we're going to work from 1 through 4, stopping at 4 to 5 for questions and comments.
And first on the phone, may I just hear name only?
Ebony?
Ebony, all right, we will circle back to you, Ebony. Let us check in the room by a show of hands. All right, we have lots of conversation here. Let's go with the 3 people in the back of the room, parallel. We'll start with Dana.
Steve Sternger with Willamette Dental, just repeating myself one more time that these roles are typically attributed to the CCO, that is for coordinating care between multiple services. The dental-only MCEs may not have the same requirements that are being laid out in this rule.
Thank you.
Go ahead. The title of this rule is not what's on the title on the RAC page, the web page. So the web page title is Integration and Care Coordination, which I think is duplicated with the first rule.
Yes.
I think this is meant to be intensive care coordination, right?
Yep. Yes, it is. So thank you for bringing that to our attention. And staying in the back of the room.
This is Barbara with Health Share of Oregon. Under prioritized populations, we feel like this is an overly broad group for such specialized service. Additionally, groups are listed below which expand upon this. Subsection 3, again, this is very large and broad. The groups in 2 and 3 above, as well as the list below, easily comprise 40% of our population at a minimum. In order to respond to this, it's just impossible. There's no way we could do this within a 7 or 3-day period with 40% of 320,000 members.
Okay, thank you for your comment. We do appreciate it.
Thank you, Jonathan, Care Oregon, JCPCO. I would just reiterate what Barbara was just saying. We similarly ran numbers, and it would be about 40% of our entire population As an example, if we have 30,000 members in CPCCO, that would require us with the 1:15 ratio to hire about 800 care coordinators to do this work, which is obviously impossible. So we would ask that we reevaluate the prioritized populations, as this seems way too broad and kind of seems to miss the point, which is intensive care coordination is served for very specific populations that need intensive care coordination.
And we thank you for your comment. Oh, please recognize in the interest of time, and again, we are here just to capture, so we appreciate the brevity that folks are using, but alternatively, we thank you because we're, again, trying to capture and not respond today. So thank you.
Lauren Dion, Trillium CCO, mirroring those two comments, similar number of runs, also similar hiring, around 1,000 care coordinators necessary, which we cannot hire at this interval. Also wanted to discuss 4B,
Okay.
A through S. Some of those we may not find because a lot of the information comes through billing, so we may not have notification of those particular incidents within those 7 or 3 days. Even with the best sharing of information and data, we may not be able to find a brand new pregnancy diagnosis within 7 days or 3 days if we aren't connected, even at the highest level. Discharges are another new chronic disease diagnosis, homelessness, those types of things are very difficult to capture.
Okay, thank you. And staying on this side of the room. Beth, go ahead.
Thanks, this is Beth from the Oregon Law Center. We would like to ask that, that embedded into this rule is requirements that there be some automatic enrollment with intensive care coordinators for certain populations, and especially kids with complex medical needs. And we could come up with a short list of others that should just automatically be assigned an ICC. What we've experienced is that people who families or individuals who clearly need care coordination, and some CCOs are left to find out about the existence of care coordination by themselves, and then B, have to navigate how to request such services, and a lot of time is lost and care is lost in that process. So we'd like to request that some categories of people, kids and adults, be an automatic enrollment into ICC and identified as such, in addition to the screening that is supposed to catch people who may not fall into those categories, but would rise to the level of needing intensive care coordination.
Thank you for that comment, recommendation.
And in sub 3, we'd like to, you've called out members with complex medical needs as those who should have ICC services available to them. We'd request that the rule additionally label folks with complex social needs as in addition to medical needs, as eligible for ICC services. And then in 4A, talks about screenings that are designed to identify people who should qualify for ICC services, and we'd like to ask that there be a specific requirement to respond to requests for ICC services in writing, and if those services are denied, that people are clearly given the right to challenge that decision.
Thank you for that. We do appreciate. I'm actually going to pause in the room, and I'm going to go to Ebony Clark on the phone. Ebony's been very patient. I want to make sure she has opportunity, just as everyone in the room has. So go ahead, Ebony.
Thank you. So in section 4B, where it talks about what would trigger a reassessment, I noticed that, so I'm thinking about the populations that might have a brief stay, in our jail system. And so I just wonder if that's an area that we want to consider as another reason that someone should be reassessed. So that was just my only comment.
So consideration of correctional contact with the correctional system. Thank you for that. Appreciate. We will capture it. Let me see, just by show of hands on the room again on this side of the table. Let's start with Allison Little.
Reiterating the comments that other CCOs have made, that this is unreasonable as far as the number of staff that would be required to hire. In addition, it does seem unnecessary for a very broad definition of this population, things specifically like women with dependent children. So any woman who has a child falls into this population. Is that really the intent? So that's comment number one. And number two is many of these are next to impossible to identify, many of the triggers. Veterans and their families. How do we identify that?
So can we pause for a moment, and then I want to circle back, Torian, but I'm going to ask Jackie or Anna to speak to this, because this is a continuing, we are getting these questions specific to these populations and where do they come from, or how is this identified as potentially, for those that have worked in Medicaid for a long time, as being those that would be identified. So I am going to ask Jackie to speak to that for just a moment or two.
Thanks, Ralph. So a number of the priority populations were identified as those being required under federal requirements of the federal block grants. So that's including,
Louder.
Oh, sorry.
Thank you.
I'm so sorry. I didn't like microphones. I'll work on that. So a number of these are required by federal block grant requirements. A number of the priority populations, including the IV drug users, the pregnant women with dependent children, and that, thanks for pointing that out, because that should have a qualifier before that, so it's not all women with dependent children. So we'll add that qualifier in there. Thanks for identifying that. So a number of these are federal requirements. Others are very high-risk populations that are high utilizers. So the intent of requiring the intensive care coordination for these high utilizers, and there's information in the rule about reassessment triggers and when someone would qualify, is to essentially ensure that we are following those members, helping to navigate the system, and making sure that they're getting the level of care that they need and not falling through the cracks and being high utilizers in emergency departments, for example. Did you want to add anything, Anna?
Yes, but our goal with this is we hear that there is 40%, a lot of your populations that doesn't meet 40%, and our goal with these standards of intensive care coordination is to lower that, make a big system change so that we no longer have such a high utilization, high needs population in our systems. We would invite this community to tell us who you think should not be on this list, then if you think we should shorten it, we welcome that feedback.
So I am going to ask that that feedback be submitted in writing due to the lack of time that we have. I'm going to recognize, thank you both for speaking to that. I'm going to recognize Lisa from Disability Rights Oregon, then down to Bill Buska, and then Cynthia Ackerman, and we will do a time check at that time.
Thanks, Rose with Disability Rights Oregon. I'll be brief. I just wanted to second the comments of Bethany Linder at the Oregon Law Center around having information about ICC shared with members, and there to be a clear way for individuals to know how to access that, and if they're denied for those services, information on their due process rights, and very clear information. And then I would also like to second the comments from the member on the phone around contact with the criminal justice system. So that's a really large part of the behavioral health, mental health population, and it would be really important to be capturing that.
Great, thank you for that.
And we will be preparing some documents that will be out in the public by October 3rd with some readiness documents regarding the changes for care coordination to assist you all.
All right, Bill, go ahead.
This is Bill with IHN, and we similarly ran the numbers of how many intensive care coordinators that we would need to meet this criteria, and it would be about 2,000 members in our 3-county region, 2,000 intensive care coordinators in our region. And so we would be happy to do intensive care coordination for all of these members as long as OHA is responsive to reviewing our rates and making sure our rates can do that work. And today, there's just realistically not even a workforce to do this. So So it's really hard to do, but it's just very unrealistic, and we really want our best intensive care coordinators to really do their work and do it well with the people who really need it. And this is just not a realistic expectation. And the other comment I have is that, Jackie, I'm wondering about the linkage between the federal block grant requirements and the managed care entities and the federal rules, and if they are linked together. If they're not, then I'm not quite sure why the block grant requirements are being added into here. But if they're linked together in the federal rules, then that's cool. And then the other one is just a lot of these things that are listed as the triggers, there's really no way that we would know any of those within 7 days, or a lot of them.
The rule does say under 4B that after notice of any of these, so it's not necessarily stating we expect you to go track these down, but if you do find out about them or someone on the care team finds out from the member, that they are asked to include those and report them as reassessment.
All right, let's go to Bill. Thank you for the comments. Let's go to Cynthia.
This is Cynthia from All Care, and everyone has stated pretty much what I have been thinking and would recommend. And I understand that there was the intent of wanting to capture all folks that need the help. My concern is that in doing that, others may be missed because you're trying to capture, these individuals. My other comment has to do with the absence of traditional health workers. Again, the level of education that's being cited, I don't see anywhere in here that traditional health workers are a part of that care coordination and carrying out the care plan.
Okay, thank you for that. Did either of you wish to?
I know that we have talked, well, I was working adding peers in, but I will make sure that we add specifically THW.
All right, thank you. Let me just do one more check-in in the room. Show of hands, anyone that did not have opportunity on this, and go ahead. We'll take, yep, we're doing all right. Go ahead.
Again, from Oregon Center for Children and Youth with Special Health Needs, I would just like to emphasize that children who are accessing services in the community often have access to other care coordinators or care managers, and I want to emphasize the importance of intensive case coordination, coordinating with the other coordinators who are out there, both for efficiencies, but also to achieve true integration into the community.
Thank you. We do appreciate your comment. All right, I am going to move us to the next piece of this rule. Anna, go ahead. And we have just about 11 or 12 minutes remaining.
Can I do the whole thing then?
As much as you can.
All right, moving on from 5 through the rest of this rule then. So big things for 5, that care coordinator assignments must be made within 3 business days. That is 3 business days after the screening and assessment period. Talking about when other appointment coordinators must be done, and that reassessments must be done within 7 days. If you find out that one of these assessment triggers has happened and someone meets criteria for ICC, when someone meets criteria, you need to notify the member by at least 2 ways, communication. We will fill in the correct rule for number 6, regarding screening, moving forward. Number 8, care coordinators performing ICC must follow this, carry out the following services. This is kind of the bones of this position description for ICC coordination moving forward.
And Anna, just to clarify on 8A is the same, you had made reference to video conference or telemedicine being an appropriate avenue if not practical, and that's samely applicable here.
Yes.
Thank you.
Face-to-face counts as telemedical here, for those who couldn't hear. Moving forward, we talk about the need to have interdisciplinary team meetings with the monthly. And moving forward, and that describes what the meetings will do. And then continuing on the next page of 11 and 12, 12 identifying some more care coordination practices. Talking about C, that there is a 15-to-1 requirement for complex care for ACC's caseload standards. I'm just going to go ahead and stop there and just start taking questions.
So, show of hands in the room. I see Sean, number of folks. And all right, can I do a check-in on the phone by name only? Anyone that wishes to speak to this? All right, I'm going to welcome Sean from SEIU.
Thank you, Sean Partman, SEIU 503. So I have a general comment. It's not attached to a particular number, so I don't know where to put it. Today, in these rules, we've had some nod to prevention, and then your comment previously, and then all these comments in the room about like 40% of the entire population, so on, which is totally unsustainable, regardless if we're actually serving them as we should. And now we have this comment under 6, like 6E, community support linkages. And so my comment to the authority is to just think through, be sure that we're really centering prevention here as part of the solution. So, putting the community support system as a centerpiece, as opposed to trying to move 40% of the entire population into like the medical system as the solution. There's a broad kind of community-based response here that we have discussed in other formats, social insurance, health, etc. But there's a role here, there's an overlap. Traditional health workers, someone mentioned, there's something there. And I can't articulate it more clearly than that.
No, we
ask you to think about it.
appreciate that, and I think it echoes the sentiments of the person who spoke about the need for aligning potential duplicative care plans that are going on from other agencies that involve other kids and social service agencies in the community. So totally appropriate, and we appreciate it. And I will ask the individual who has gone on Muzak to go off, or please pick up the phone.
I'm not going to be able to hear you.
All right. Other members of the RAC and general public, we're going to do the very best we can. I apologize for this. I don't want to disconnect at this point and run that risk with all of 15 minutes left to go in this meeting. I will ask again, will the individual who cannot hear me, oh, thank you, we appreciate, oh. All right, we're going to do the best we can, everyone. Go ahead.
Comment about interdisciplinary team meetings, the potential for the large volume of those that are required in this rule. They can really generate provider abrasion and actually not serve the purpose that you're hoping for.
Thank you for that. We appreciate staying on that side of the room.
Can you repeat that comment for folks on the phone?
I will try to repeat it over the Muzak of the other individual, but to paraphrase, I think that the term used that Dr. Little used was provider abrasion, and that potentially there could even be some diminishing return on compromising those relationships at the provider level if you're living in care coordination meetings all day. Is that a fair summary? All right. Everyone on the phone, I regret this and I apologize. We are going to hang up and dial back in very quickly. I don't know any other way to mitigate that because I'm sure, I'm telling you, it will not take care of it.
I don't think so.
Well,
No, because they'll still all be on the line.
Okay. Everyone on the phone, we apologize. The person that is the culprit may not be aware of it, so we cannot take aim at them. But again, we are really trying desperately to make sure that everyone has the opportunity to participate and understand what's being said. So we're going to carry on, and we apologize. Go ahead, Cynthia.
Okay, Cynthia from All Care. I think the gentleman from SEIU actually articulated it very well. And it reflects more of what is existing, what has happened that worked well. And I'm not saying that there haven't been gaps, but I actually think he did a great job of stating that someone may already be case managed, say with the DHS office. And I just want to, I think that concept is capturing the concern, at least we have, regarding the numbers required. Yeah.
I do want to note too, in the rule, and I apologize for not calling this out, there is something regarding if a member is already in a specialized program, so if they can like ACT or ESA or wraparound kiddos, then that would suffice as their ICC coordinator, or if they're already having that extensive care being done, and as long as that's like in the chart and obviously clear, then that would suffice, and the CCO would delegate that responsibility at that point.
And again, I want to state, identify the gaps and figure out how to tackle those gaps and mitigate those gaps in the care coordination.
Thank you.
All right, go ahead, Dana Starringer, and we'll continue around the back of the room, and we're at just about 6 minutes. I will make one more plea to the individual on the phone who has muted their phone, who has put the room and whoever else is participating with us on their music. If you would please, or if you have a colleague on the phone that's also listening, please instant message or email the individual. We appreciate your help. Thank you. Go ahead, Dana.
So, Dana Sturgeon with Willamette Dental, just a couple technical comments. So, number 6, there's 2 number 6s. We saw that, but one of, obviously the second one should be 7. So 7 would be ICC activities included. Under number 8A, the first sentence is talking about meeting face-to-face with the member and doing so for the initial and existing acquaintance. And that to me sounds like a provider interaction as opposed to anything that would happen with a care coordinator at a health plan. And then my last comment is on the last page, under number 13, it's talking about being consistent with OER 14.1. We're referring to the rule itself, and then the name of that rule is incorrect. So I don't know the name.
Thank you.
Rule in that rule.
A work in progress. Thank you.
Renumbering.
Go ahead.
Barbara with Health Share of Oregon. I just want to reiterate Section 12, subsection C, that it basically states that we have to have a ratio of 15 to 1 per care coordinator. And again, we ask that this particular section be deleted. It would take over 8,500 care coordinators for Health Share to manage that.
All right. Thank you for the comment. We appreciate.
This is Marilyn from Oregon Center for Children and Youth with Special Health Needs. I want to comment again about the variety of case managers or care coordinators that kids with special health needs likely have. It's still critical that health be a part of their care plans. And so I would advocate for kiddos who have other case management to be integrated with what intensive care management is doing and not to be excluded from that.
Thank you.
Lauren DeYoung, Trillium CCO. Reiterating that 15 to 1 ratio being very difficult to achieve. And then in combination with 8A with the face-to-face components. So not only do we need the care coordinators to just outreach to the members, there's also proposed a face-to-face component which then reduces the ability of the care coordinators to be interacting because face-to-face care coordination takes a lot longer than some of the telephonic interactions to coordinate care on the back end. So you could be spending hours with a member, which you need to do to develop a great relationship with them, to service them, but then your ability to manage ongoing, unless we're in this 15 to 1, you have thousands of case managers available. So I would propose maybe consideration with the community and other providers who have care coordinators, so expand that definition of ICC so we can delegate, defer, or share the prioritized population care coordination with existing entities that do it regularly.
Okay. Thank you. And continuing along this side of the room, Beth, go ahead.
This is Beth from Oregon Law Center. Could you explain sub 6, the second sub 6, and ICC activities include? Could you explain the agency's intention? Is this when you say it doesn't say shall include at a minimum? It doesn't say may include. Is the intention that this be a list of examples, or is the intention that this be a list of things that are required to be provided? in intensive care coordination?
I think a word like shall is missing here. These are things that are part of the activities that they should do, so we'll definitely make that edit. Thank you.
And I'm going to go, we've got approximately 1 minute. I want to make sure that everyone on the phone, RAC members only, is there anyone by name that would like to speak to this, the last piece of this rule?
This is Robin from UHA.
Go ahead, Robin.
I just wanted to state for the record that also from UHA do object to the 15-to-1 state care center ratio.
Okay. Thank you. I apologize. I'm going to need to speak over the MUSAC here. Just for the benefit of everyone in the room, I think Robin's comment was consistent with that of other plans that have made comment about the 15-to-1 ratio. And everyone, I sincerely apologize for the inconvenience that's been caused by this and the difficulty. We will work to overcome it tomorrow. Do we have Lisa McMahon from the Oregon Foster Youth Association with us?
You do, and I've also emailed my comments if it's easier for someone there to read them versus me saying them on the phone. Can you hear me on the phone?
Actually, I hear you on the phone, and I'm going to ask you to make your best foot effort to do that. I think that would be most appropriate. And you do have the attention of the room at this time, and I apologize that you'll need to speak over that music.
Thank you. Again, it's Lisa McMahon from Oregon Foster Youth Connection. So in reference to the 410-141-3860, echoing the feedback of coordination of care from the youth or the child system to the adult system, additionally highlighting when youth exit foster care, sometimes that's not till age 21, so that the transition of care might be different at that age and they will still need lots of support. The 410-141-3865, I initially had a question about will all foster youth receive a care coordinator even when they move out of the area, and that seems to be possibly answered in a later rule. Number 7 says, my question is
Sure,
if someone does not want to
Lisa,
have...
I do need to interrupt you in this public comment, and that the comment process itself is strictly to offer public comment, not a venue or forum for the general public to submit questions. I just need to provide that level of clarity.
Okay. So then I would just say that I think foster youth should be receiving coordinated care as one of the populations stated later. Number 7, I'm in 3865. Number 7, I'm curious if people will be offered the opportunity. It would be great if people could be offered the opportunity for care coordination at a later date if they choose to opt out of it at some point. I am hoping that a specialized facility in number 9 includes residential placements or other specialized placements for foster children and youth, for instance, a BRS placement. In 410-141-3870, I wanted to highly support children in care and children 0 to 5 at risk of maltreatment to be eligible for the ICC. And then I'm also just hoping that that care coordinators can get support maybe from the agency to know if foster youth have moved, that they can know that in reference to number 4, letter B, K, L, and O. Number 8, letter E, the interdisciplinary team. I think maybe highlighting, and I think other people mentioned this, that youth in foster care also have a support system, a school. There's a lot of players involved in their life, a lot of different coordination meetings. So I would just hope that all of those coordination meetings could happen at the direction and the desire of the young person. Thank you so much.
Thank you. We appreciate that. In closing, for those participating on the phone today, for our 2 RACs tomorrow, the worst case scenario for us is that we have to mute the entire line, including those seated RAC members who would participate on the phone. to facilitate a successful meeting here in the room. That is not something we want to do. So when we send out our evening note tonight of invite and agenda, we will make special note to remind people not to go on mute on a system that could put their phone or hold that could generate a Muzak tone. If that happens, I am saying at this time, regrettably, we will need to mute the entirety of the line that would preclude the general public from listening and seated RAC members on the phone from participating. It is not our wish to do that at all, but if we are left with no other alternatives, we will, so that we can run an efficient meeting here. Thank you. This concludes our RAC, and have a good day. Thank you.